Are you curious about Gestalt language processing? You are not alone. Join me, Corinne Smoose, and Speech Therapy PD for our podcast, The Gestalt Get Together. Our episodes try to balance the enthusiasm and excitement about GLP and its associated intervention ideas, as well as a healthy dose of skepticism about how to understand and integrate this paradigm shift into your career and the field at large. We hope that you can get together with us to learn more about Gestalts.
Hi, everybody. Thank you so much for being here. And, we start here with our disclosures and so on. I'm kind of getting figured out here, but just to get these over with, that regarding the financial disclosures, Dr. Reed is the author of the book, The Source for Counseling for SLPs, published through the former Linguasystems Company. And she also receives an honorarium for this podcast from SpeechTherapyPD.com. Personally, I too receive an honorarium for this podcast, and I'm a regular seminar presenter for SpeechTherapyPD.com, and I own Speech Dynamics. Regarding non-financial disclosures, Dr. Reed is the chairperson of the International Association of Orofacial Myology, the IAOM, Institutional Review Board, the IRB. And personally, I have no non-financial disclosures. All right. So I'm so glad that you're here for our live SpeechLink podcast, sponsored, of course, by Speech Therapy PD. And I'm Shar Beauchart, your speech language pathologist host. And I'm so very glad that you're here for our practical topic, really practical topic, implementing client and family counseling and managing difficult situations. Dr. Hope C. Reed, SLP.D, CCC-SLP, COM, and ASHA Fellow, earned her doctorate in speech-language pathology from Nova Southeastern University. She is a fellow of the American Speech-Language Hearing Association and is professor of communicative sciences and disorders at Alabama A&M University. And she joined the faculty there in 2002 and teaches graduate and undergraduate courses in counseling, craniofacial anomalies, articulation, phonology, language and fluency courses, as well as methods and materials for school-based SLPs. In addition, she's a certified orofacial myologist and has established the world's first university-based clinic for children and adults with orofacial myofunctional disorders, which was the topic of her first SpeechLink podcast. She prefers for us to call her Hope rather than Dr. Reed. So a hearty welcome back to the SpeechLink, Hope.
Thank you, Shar. I'm happy to be here. Any day I get to speak with you is a good day.
That's so sweet of you. Oh, I love talking with you too. I know we were on Zoom the other day and I said, oh, it's just going to take 15 minutes. And I think we were on for 45. So
We were. I enjoyed it though. I liked the extended time.
Me too. Me too. I always enjoy speaking with you.
Thank you.
So today we are talking about counseling, which is not something that we typically talk about in our field. But nonetheless, it does take specific skills, I'm going to say. And to start off, just what are the skills or the characteristics, and this is like beyond SLPs, what are the skills or the characteristics of a good, effective counselor? Let's start
Well,
there.
there's lots of skills. I actually taught this part of this today in my counseling class to my seniors. I'm just going to list some of those. There's a pretty wide list, but skilled counselors, speech language pathologists, we have wisdom, we have dedication, self-awareness, we have good communication skills, I hope, empathy, objectivity, trustworthiness, competence. We are flexible in our thinking. We can be spontaneous in our actions in the therapy room. So we can change gears when we need to quickly and shift or pivot, the popular word these days. We have emotional stability ourselves. We're honest and open without being brutally honest or too frank. We have a positive attitude. We can motivate others to change for the better. And we're able to concentrate and focus when we need to.
Wow. Those are all really good skills.
Mhm.
And I'm going to say those are skills that some of us just have out of the gate, and others, some of us need to experience them and train them and become more aware of them, that it's something that we need to do and be over time. Would
Right.
you
Yeah, we
say
have to
that?
cultivate them.
We cultivate. Ooh, that's a really good word.
Mhm.
And I guess cultivating something comes from experience.
Yes, and that's what I tell students when I introduce those. We go through that list and we talk about what that means as a clinician and a counselor. And one of the things that I focus on with them, because they're beginning in the field, they're about to enter the field. And I tell them, I don't know anyone who comes to the therapy table with all of those skills perfectly intact. I know personally, after 26 years in this field, I'm still cultivating and doing better in those areas as well. So that's what clinicians do. We try to get better and better and better.
That would be a good list to just post on my wall,
Yeah.
and just work toward, to be aware of them. Because, I think that many times we think, oh, it's just the therapy techniques, but really it's a lot of those things. Would you mind, do you have them there? Did you read them?
I do. I have them on a
Okay,
PowerPoint slide.
would you just say them again?
Oh, sure. You want me to list them?
How would you just
Oh,
list them again? Because I
sure.
remember self-awareness. That's a really good one. But what are some of the other ones again? Tell me again.
Wisdom,
Good.
dedication,
Mm-hmm.
good
We got that.
communication skills,
We're working on that.
empathy, objectivity, trustworthiness, competence, flexibility and spontaneity, emotional stability, honesty and openness, a positive attitude. We can motivate others to change for the better. We can concentrate and focus when we need to.
Mm-hmm.
And that rounds out the list.
Wow. And a lot of those overlap, don't they?
Yes. Yes. Obviously, if you're trying to seek, you know, one example is trust, and patients, caregivers, students, they will trust you initially just by virtue that you have a title and that you have credentials. But if you want to maintain and continue to earn that trust long term, then they have to see that you're knowledgeable, that you have empathy and care about them in the long term.
Mm-hmm. Mm-hmm.
And they also learn to trust you by, if you say you're going to do something, you do it, you follow through. If you say you're going to call, you call. If you say you're going, we return our emails, we call. And even if we don't know the answer to something immediately, we follow up with them. And that's, that takes discipline, but that's also, one of my colleagues used to have this on her office door: education. The idea behind education is self-discipline, being able to do what you need to do when you say you're going to do it. And that helps build trust with patients and families too.
Mm-hmm.
But
Mm-hmm.
initially they will trust you just because you have a title, and they'll give you that benefit of the doubt and the chance, but you've got to earn that long term.
Yeah. 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 And I bet that has to do with improvement. So that if we're working with a child and that child is going to have trust, I think that children are just so very trusting, and the parent, as you say, is going to trust us initially, but that parent needs to see some kind of improvement, no matter how big or how small it is.
Right. They
And
need to see
that's,
value in what we're doing and
yeah.
what they're doing, and that it's moving the situation, the communication disorder, the swallowing disorder forward.
Mm-hmm, mm-hmm, yes. And see, that is such a big piece. And, if a therapist is in the schools, it is so hard to, we could reel off all the things that we need to do in the schools. And, contacting the parents is, I don't want to say it's at the bottom, but it needs to be at the top, but it's an extra step. And
Yes.
sometimes parents are hard to get a hold of and so on. But that parent, and even if we just write a note or we text them or we email them,
Each notebook.
yeah,
Mhm.
there you go. And just in some way touch bases with them
Mhm.
so that you can either state that, oh, you know, Susie, Johnny, Tony, Jose, whatever, Maria made just did this great improvement today. And, you need to know about it. And so that the child can share that with you and so on, so that there is that communication piece. Or here's something that I'd like you to do to follow up. And it's doesn't take much, but if you wouldn't mind just doing that so that that parent feels involved. Now, some parents don't want to be involved. There's always that. And maybe we could get into that can be a sticky situation, when you have a parent that, hey, just fix my kid. That happens.
Yes.
So that may be one of those situational types of things that what do you do? But that trust is just so very important. I'm going to say much of therapy evolves around trust.
Any relationship revolves around trust, and that's what we learn in counseling. Luderman, you mentioned the school setting, which many of our clinicians, the majority of ASHA certified clinicians are in school settings. Luderman says in his books, various editions of his seminal counseling text, he says it's difficult to do counseling for the SLP in the school setting, not impossible, but it's more challenging because we also take on the role of change agent. It's not like a private practice situation where the parents or grandparents, aunt, uncle may be sitting there with the child interacting, or at least observing therapy like they do in our university clinics. The parents are, the child's at school, the parents are likely at work or, at home caring for other children. And so we take on the role of that change agent for that child. It's almost like a parenting role. We're kind of the go-between between the child and the classroom teacher to help the child be successful socially and academically. But then we also have to interact with the parents as well. And there's some great little resources out there. I think of some publications out there. You can just copy a page and just clip a little piece out that says, hey, I worked on this sound today, or I did a good job in speech therapy. And, just put it on the child's folder or on top of their papers that they go home with. Now, if they make it out of the backpack, I don't know, but, we at least are sending them home.
Yes. Yeah. Sometimes they get shoved to the bottom.
They do, and they end up crumpled up, but they're
That's
there.
right. That's right.
We try.
Well, and that's part of the responsibility at the IEP, I think, to sort of say, hey, I really want to stay in contact with you. What would be the best way? And if it is sending home notes and maybe you have a common folder and it goes back and forth, then just say, hey, please look for that folder to come home. And maybe that would be another step so that that's kind of agreed upon at the IEP. And
because we're all responsible for implementing that IEP. It's not just the SLP or the classroom teachers, the special ed team. It's, the parents have that. And I believe most parents want that. They want that involvement. They want to help their child. And, but parents are parents first. They're cooking dinner, they're clothing the child, taking care of the child's emotional, physical needs. And so what we send home to them for practice, if we expect them to read a note or some kind of feedback, it needs to be in very digestible pieces. Because their time is limited. They're parents.
Yeah, exactly. Yeah, well, and that's, that's right. Yeah, they're juggling many things. Yeah, I totally understand. I remember those days. Oh, man. Okay, well, those are that's an exceptional list and exceptional qualities to really strive for all of us. And that's counseling, period. Now, when I think of speech language pathologists, the first thing that I think of is not, oh, I have to learn to be a good counselor. That's not the first thing that I think of. And, what are going to be situations that call for counseling? In let's say in the schools or even, maybe private practice, maybe in the hospitals or clinic or whatever, what situations call for counseling? And we could even look at, the client, him or herself, the parent, teacher, et cetera. But what situations? Do you know what I'm saying?
Yes.
Yeah. Like at the IEP, there may be some counselings there, but Specifically, what are we talking about?
Well, in the public schools, which I came out of the public schools, that's where one of my first settings, IEP meetings. This may be your chance because you've performed the eligibility, so all the testing, and you're presenting, you may be presenting those results and leading into putting the IEP together. So you may be explaining, it may be an educational component, but I'm very emphatic with my students that counseling, part of that is information giving, but it's not just information giving. So you may be explaining what a disorder is, but I've had parents sitting there, maybe not at the IEP meeting, but in the public schools working with preschoolers, where they were handed an enormous report, pages and pages, and it says your child has autism. And I think we expect people to understand what autism is these days, but I think when it's your child and maybe you didn't see that coming, that there's an emotional piece to that, and they're sitting there crying and they're upset and they're scared. And you may be briefly explaining what autism is, but this is what it means, and this is how we're going to work to mitigate the social, academic, occupational, the fallout from this. But you also have to help the parents. And initially, you're just dealing maybe with that shock and trauma. And that happens in the hospital setting too, for our more medical-based clinicians. A family who's maybe a child, a newborn with a craniofacial condition or a genetic syndrome. What I tell my students is, in those situations where it's a new diagnosis, the shock, the trauma, I say feelings first, content second. And so a lot of times it's just that listening piece, and listening without an agenda, meaning what am I going to say next? And I'm a big believer too that people will ask the questions they're ready to hear. And many times I think they already know the answer too. Maybe there's a technical piece where we come in, but yeah, feelings first, content second in those new shock situations. Now, then we have a situation, deferred diagnosis, where maybe it's usually mom sees that something developmentally has not been on the necessary trajectory or the expected developmental path with a child. And mom has usually voiced this to dad, other friends. I find that other friends tend to talk mom out of it. They're not being malicious, but they may tell her, oh, everything's okay. But mom in her heart knows there's something amiss here. And so that's a little bit different. She's probably been coming into this knowledge and this awareness over time, but still, I was telling my students today, I go back to that person-centered theory, that humanistic theory, where I'm just going to do a lot of listening, non-judgmental, and there's not really anything they can say to shock me or cause me to judge them. They need that, and through that warmth and empathy, then I move more into, and they feel comfortable with moving more into change, behavioral change. And then that's where I usually loop in that cognitive behavioral approach. But I don't want to ignore that emotional side. Now, we can't let people drone on and on about, their life story. And I always tell my students, from the time they left the birth canal. But, there's a time and a place. People want to be, this is what I've learned over the decades. People want to be listened to. They want to know they matter. And the patients and the families and the loved ones, the caregivers, want to know that what they're doing matters and that it's recognized and appreciated. Even if it's, like you said earlier, Shaw, those small, maybe sometimes we just get small pieces of progress. Sometimes they're bigger leaps in progress, but no matter what, people want to know that they matter, and they want to be recognized for trying. And they want to be, people want to, again, not droning on and on, but people want to tell their story. I even find that with my tongue thrusters, which is typically not an emotionally burdensome condition. But sometimes I get adults who are on their third set of braces, and no one ever told them about this thing called tongue thrust. And maybe how they had fixed the tongue thrust, that would have helped mitigate that orthodontic relapse that they're seeing. But they all even though that's not an emotionally heavy condition, like I said, they want to have a chance to tell me how they got to me. What led me to your therapy room, to your door, to your clinic. This is what I've tried, this is what I've been told, or, orthodontist, dentist in the past, or this is what I was never told. And, they just want to know that their journey to you matters.
Yes, yes. I totally agree. I remember when I was at Loma Linda University in the speech language pathology department there, and I was kind of in charge of the clinic, and we had a lot of people coming through. And I tried different approaches of starting out, when we all sit down, what do I say?
Mhm.
And when I said the words, what can I do for you? That
Mhm.
seemed to open things up. When I didn't say that, or if I just said, "Oh, you're probably here because your child is having some speech issues and you're having difficulty understanding your child," and so on, it didn't go as well. But it
Yeah.
opened up that opportunity for the parent to express themselves. And I think it's important for them, but it's also important for me to understand where they're coming from, because
Mhm.
that parent knows their child obviously much better than I do.
Yeah. And
So
I
that,
find too, I can ask the question to parents or an adult patient in my, when I'm doing tongue thrust therapy, myofunctional kinds of things. I can ask them, what do you expect of me today? Because we're so
yeah.
into what should the patient do, what should the parents do, and we in our minds know what we should do, but what do they expect of us? And I'll say,
Mhm.
what are your expectations for today? What would you like to come out of this session? This is the diagnostic
Right,
session I
right.
do, which I can generally do in one session. What are your expectations of me? And, inevitably they'll say, and, they're looking, and this is interesting because my name is Hope. Inevitably, they will say, I just want to know that I can fix it or make it better. You've
Mhm,
come to the right place. We can do
mhm,
that together.
mhm,
So, and
mhm.
I find another good question, you made me think of this. Sometimes, especially with stuttering, child language, it helps to ask the parent or the caregiver, well, what do you think is going on here? What's your explanation for what's happening? Because especially with stuttering and child language, I find that can be a chance to kind of myth bust. We get the caregivers who come in and say, the child listened to a certain cartoon or cartoon character as, for a few episodes, and now they're talking like that cartoon character. Well, we know as clinicians that doesn't cause true stuttering, developmental
Mhm.
stuttering. So that's a chance to myth bust. But then sometimes they tell you things that are grounded in the evidence. It's oftentimes they'll say, I talked to my mother-in-law and my husband stuttered or had some disfluencies, issues as a child, or the grandfather or the uncle.
Mhm.
And that's a chance to say, well, there is some evidence that there is a genetic component there. But then I'm always careful because this is where that counseling piece comes in. How is that going to come across? It's not about blame because, and I tell them, but your husband or the grandfather or the uncle didn't have a choice in what genes or DNA they passed on. None of us really do unless we get into complex genetic engineering. But you know, and I also remind them, this is what counseling has taught me as well. I remind anyone who says, I have someone I'm working with right now, a tongue thruster. The mom was a tongue thruster as a child and worked with my mentor who taught me all about myofunctional disorders.
Hmm.
Um, and I said, there is a genetic component, can be just about anything. There can be a genetic component, but there are so many, you didn't have control over passing. If that was in the DNA, you didn't have control over passing that on to your child. And don't forget about all the remarkable things you passed on to your child and who
Mhm.
your child is because of you. And there are so many more wonderful things than this one thing that we're going to work on, and we're going to do our best to fix it in the case of tongue thrust. And their face just lights up when I say that, because it's easy to get mired down in, oh, do they do this because of me? Because I did this as a child and I had this condition. but you passed on so many, and that's when I'll say, look at this child. This is a bright, intelligent, caring, compassionate, fun little person you brought into the world. And don't forget that, we can fix the tongue thrust.
Or the speech problem, or yeah.
Yeah.
There you go. Good.
Yeah. Or the language. Yeah. The language problem.
Sometimes the
Absolutely.
language. Yeah. Then we can at least improve it and so on. Yeah. Good. Good.
Yeah.
Good. Oh,
We
I
can
like
move in the
that.
right direction.
Yeah. I like that approach. I like that approach. It's all quite complex, but it's all quite logical. There's a lot of common sense and really focusing on the other person and being mindful of how they're going to interpret what we say. Yeah, really. Okay, good. So have we crossed over into counseling strategies or mantras? I know that you mentioned about mantras and so on. What's the difference and how do you describe strategies, counseling strategies, counseling mantras? I know that you were talking about those on
Well,
Monday.
my counseling mantras are not so much, they're things, the mantras are more of the things I'm constantly reminding myself of and the things that I want my students to take away when they take my course in counseling or when I do a presentation at a conference. I want the takeaways. Then there's counseling micro skills, which is, a separate, reframing and counter questioning. So, but some of the mantras, I've already talked about people want to know they matter, their journey has mattered. And there's another one of my mantras is, and I think I got this must be in my mind from a textbook somewhere, but I don't have the quote, the person who don't have a credit for it in my mind. Two things: you can't pour from an empty vessel. And so I'm really big these days on instilling in my students that we need to take care of our own emotional and mental health because it is harder. It's harder to work with people who have disabilities. It's more taxing because it's just more challenging. And we can't help others if we are a dirty Band-Aid. So if we are not taking care of ourselves, we can't take good care of others.
Oh,
and then
that's a biggie. That's a biggie.
That's huge, especially these days, because
Huge.
the Surgeon General in the United States has identified loneliness and this mental health crisis as, it's the top, the biggest problem in our country right now. And we have to learn to take care of ourselves so we can take care of others.
Wow.
We just had in my area today, they just opened up a crisis center for children who are experiencing mental health crisis.
Really?
And our governor was in town, here today to open that facility. And that's, just recognizing that piece. So we have to take care of ourselves so we can take care of others. It sounds cliche, but it's practical and it's true, which is why it may sound cliche.
Yeah. Wow. Wow. That's huge. That is huge.
Would you like for me to do some of my other mantras?
Yes, would you please? Yes, I like these. These are good.
Another one, this one resonates with my students when I teach craniofacial anomalies at the graduate level. And I can't take credit for this one either, but I learned this from reading the book Wonder by R.J. Palacio is her name. She talks about the nurse in the book, the child, Augie, has a craniofacial condition, probably Treacher Collins is what I ascertain it to probably be. No one congratulated those parents at the hospital until this one nurse they talked to at the craniofacial center in the book when they were setting up the initial appointment to begin his path of treatment, surgeries, and that sort of thing. And the parents in the book remembered that. No one had congratulated them on the birth of their newborn at the hospital. And then they talked to this nurse. So I tell my students, when you're working with families, if you're working in a hospital setting or where you might encounter children, or, that's supposed to be a joyous event, the birth of a child. The two best days of my life, the days my children were born. But I think that parents who have a child who's born with some kind of condition, such as a craniofacial one, they get robbed of that. They get robbed of that happiness. And so we don't want to forget to congratulate them on the birth of their baby. And so that's been a big takeaway for my students. I see it in their eyes. They're like, oh yeah, we would have to remember to do that.
Yes.
Because we just see the negative sometimes. It's easy to get caught up in that.
Yeah, it is.
My favorite definition of anger, I've learned when people are angry, when they're frustrated, they're probably angry because they're scared. I think there's a lot of anger is rooted in being afraid. And I've just learned that in my own life experiences. And my favorite definition of anger is it's a violation of expectations. And parents, caregivers, patients, adult patients especially, maybe if they've had a stroke or head injury, they were moving along through, their life and things were just going well. And then that stroke or that accident happens and you see that frustration and that anger, but it's because, they didn't expect, they weren't looking for that to happen naturally. I don't know anyone who would be. And so it helps me and this doesn't happen a lot, thank goodness, but if a parent or a patient or someone is angry, I've learned not to take that personally. I've learned to look at, is this person afraid or scared or worried or anxious? And if I can put it through that filter, then I'm better equipped to not internalize it and take it personally. And I think I can help them better if I realize where that anger or that frustration is coming from.
Yeah. Yeah. And what was that definition of anger again? Something about expectations?
Yeah, anger is a violation of expectations.
A violation of expectations.
Yeah. Yeah. Think about it just from a practical standpoint. If you're in rush hour traffic and someone, because of course driving, we may have expectations that people will behave badly. But we get angry because that person cut us off, and gosh, even though I've driven for X number of years, I didn't think they'd really do it. I didn't think they would really cut it that close. And we get angry because it violated our expectations of what we thought, should have happened in that situation.
Interesting.
So that's something that helps me. So those are,
interesting.
I would say some of my big mantras.
Well, and that reflects back to, what you were saying about asking that parent or the older client or even the younger client, what do you expect from me, or what are your expectations? Yeah, the expectations piece. I think that has a lot to do. And I know I've remember I did a course on motivating and establishing expectations and so on with children in the schools. And it's very common for us to say, I expect you to be here on time. I expect you to attend. I expect you to keep your hands to yourself. I expect you, I'm going to give you some speech or language homework. I expect you to, in so many words, to do it and to improve and so on. I have an improvement expectation. And then through the years, I did learn to sort of turn it to them and say, now, what are your expectations of me? And that's always, it was like this, huh?
I know they give you this look like they're in shock that someone would ask them, what are your expectations? I've done the same thing sitting there. What do you expect of me? And because I'll do that in my clinic at the university. I'll say, okay, I expect you to show up and to have practiced your exercises, consistently, conscientiously, and that we pay attention in therapy. I try to keep it to about 3 expectations. And then I'll say, and what are your expectations of me? And they almost fall out of their chair sometimes. I've seen not so much the child, but the parent, because they just don't typically get that from other professions, that they encounter.
Yeah. I think it's a good thing to do. I don't even look at it as, I guess it's a strategy, but I think it's just a very helpful thing to do when it comes to establishing a working relationship
Yeah.
and kind of a give and take and an involvement where everyone is connected and on the same page and moving together,
Yeah,
through the
I talked
improvement.
about that in class today. It's a system. The therapy relationship is a system,
Mhm.
and uh, what one person does in the system affects other people or other persons in the system, and vice versa.
Mhm.
Yeah,
Mhm. It's true. It's
yeah.
absolutely
It's
true.
symbiotic. That's my new. I told my husband
Ooh,
the other day. That's my new buzzword. Is symbiotic.
ooh, yeah, I
I know.
like that.
I know. I'm
I like
using that.
that.
I work that into conversation a lot these days.
There you go. I like that. Yeah, that's a good term.
Mm.
I'll have to start using that one.
Yeah, work that one
Somewhere
in because
along the
it, it
line.
it amazingly works pretty well in a lot of situations. Yeah,
Yeah, yeah.
yeah, it's my
Oh,
new
good.
buzzword.
Yeah, good. Yeah. Yeah, I would think it works quite well in marriage. You
Yes,
know? Yeah. 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 Raising
absolutely.
kids. Yeah. Yeah, it is
Mhm.
a symbiotic
Yeah,
relationship.
it definitely is. Yeah, it describes
Hmm.
that family system pretty well. It encapsulates it very well.
Yes, yes, definitely, definitely. Oh my gosh. Okay. So those are some mantras. Did you have any other mantras that you wanted to share with
Oh,
us before we move on to the strategies? You named a couple there.
yeah.
But mantras, anything else on your list? Those are all good
Well,
ones.
yeah, something I'm working on right now with my students. I revamped every few years I'll revamp a course. I'll say, do I really need to be spending time on this? What are some things I could, as I grow and learn as a clinician and evolve as a clinician? Um, so right now I'm really big with my students. I've added a unit on congruence. I'd already always talked about congruence, but
Hmm.
now I'm really honing in and drilling in on congruence. Um, Congruence in counseling is, those of us who are more logical, analytical thinkers, we need to become more in tune with our emotional side, and and vice versa. Those people who are more emotional thinkers need to get more in tune with their logical side. And we want to cultivate that, encourage that in patients, but we also need to cultivate that in ourselves. So that's something that I'm really drilling down on with students. And I guess another one would be trusting patients if it's an adult patient, and caregivers to make, patients to make decisions for themselves and caregivers to make decisions for their child or their spouse, their loved one. And the last one I'll do is changes. I do an entire unit on this in my adult fluency course or my graduate fluency course. Change is hard. I do an entire module on change and what it takes to change a behavior, change yourself. It takes commitment and it takes good timing. We have to have the time and the energy to devote to it. Anyone who's ever done any kind of therapy, whether it's seeing a counselor, mental health counselor, physical therapy, if it's stuttering therapy with what we do, for example, it takes commitment and it has to, you have to say, I'm going to take the time and the life energy to make this situation better. And now's the time to do it.
Wow.
Yeah.
Yeah. And then stick with it.
Yes.
Yeah.
And follow
Yeah. Over
through
time,
on it.
follow
Yeah.
through.
Yeah. I tell my students, because I see adults and children, in my clinic at the university, the children tend to be very consistent about showing up for therapy because their parents or grandparents or if a loved one is, driving them to the clinic. Adults, that's where I see the breakdown in attendance because adults have competing, they have jobs and a mortgage to pay and, they've got kids themselves maybe. Um, when there's a breakdown in attendance to the therapy sessions and no shows and cancellations at the last minute, it's usually an adult patient because they do have those competing interests. And that's hard, but that's part of change. Is I'm going to make this a priority, in light of the other priorities and things that I have to accomplish and do each day.
Yeah. Yeah.
Yeah, yeah.
Yeah. Well, that is interesting, isn't it? That
Mm-hmm.
the same parent will you know, get the child into the car and get
Mhm.
down to the therapy
But
clinic or
not
wherever it
themselves.
is, but not themselves. Yes.
Yeah,
Yes.
yeah,
Yeah.
yeah.
I hate to say, I could probably see myself doing that. You know, I have a
And
responsibility to
I
my
could be
child to
guilty
do
of
that.
that on any given day too. But yeah, there's been a few times over the years I've had to have that discussion with an adult,
Yeah.
patient. Maybe now you don't have the time to devote to this therapy. And it doesn't mean that you're a failure. It doesn't mean that you have your priorities misplaced necessarily. It's just that you've got too many competing demands, and there's only one of you to go around. So I had a person one time who was having trouble showing up for therapy. He was a paramedic or an EMT, and that's a very stressful, I mean, high
Oh, yeah.
stress
Oh,
job.
yeah. Yeah.
And it's okay. It's okay to, I tell them we're not pushing the stop button. I used to say on the VCR, I can't say, no one knows what a VCR is now. We're not
Yeah.
pushing the stop button, we're pushing the pause button. And I'll be here if you need me. I plan on being here if you need me, you know. And sometimes patients will, they'll come back in and they'll say, okay, I'm ready. I've got things, more in line with where they need to be for me to dedicate my time and energy to this.
Mhm, mhm.
Children, it's a little different if the child is having trouble staying on task with treatment, because after about 3 sessions, I expect that mom shouldn't have to be standing, looming over them to get them to do their exercises. So children, they tend to see it more as, oh, I failed because, we need to put this pause button. And it's usually with little boys, it's usually a maturity thing, and they just need a little time. They're not developing people don't do things and behave on our timeline, and with our expectations. We can encourage that, but people don't operate on Hope Reed's timeline. Sometimes Hope Reed doesn't even operate on her timeline. So, yeah. Yeah. So those are
Oh,
some of the
yeah.
things I could go on and on, but yeah,
Yeah.
those are some of
Yeah.
the things that I try to remind myself of
Yeah. Yeah. Well,
that help
good.
me.
Well, good. Well, good. Now, you mentioned two strategies maybe 10 minutes ago that flew
Mhm.
right over my head, and I'm thinking, ooh, what are those?
Oh, the counseling micro skills. Yeah.
Mm-hmm.
It is the reframing and
Mm-hmm.
the counter questioning. Yeah,
Mm-hmm.
we have
Mm-hmm.
some actual skills. I teach about 6 of them in my counseling course to students, and one is reframing, and that comes from rational, emotive, cognitive, behavioral therapy. And reframing is, now you can't do reframing when there's a new raw diagnosis. You can't do this. Otherwise, it's going to seem like you're a jerk if you do it. So timing is critical. But down the road, after a parent has had, I don't know, a child who's been diagnosed with a condition, and this is months or weeks or maybe a year into it, and they say, why me? And you say, you can reframing is where you take something negative and you turn it into a nugget of gold. And but that's why you can't do it early on. You can't do it at the hospital when the child has been born with a genetic syndrome and everything's raw and fresh and very emotional to the parents. But you can say, well, let's look at why maybe this, and there's a little intellectualization there. Sorry, it's late in the week. I'm getting a little disfluent myself. But you can take
Good.
what is viewed as a negative and turn it into a nugget of gold. And it can seem kind of crude, but it's not. So trying to think of a specific example. Oh, okay, yeah, here's one I give my students. So a parent is complaining about, people are always staring at my child's hearing aids, or, they're asking me questions. What are those things on his ears? Because, hearing aids are real, to me, hearing aids are, they've got some pretty cool components these days with the ear molds they can do with the glitter and the confetti and the bright colors. But a parent says, why are people always staring at my child? Why are they asking these questions about what my child has on his ears? Reframing would be, well, this is a chance for you as a parent of a child who's hard of hearing to educate other people about the advances in hearing aids and the molds, and the technology advances.
Yeah.
Now, obviously, you can't do those things when that child has just been diagnosed and the day one they get the hearing aids, but down the road, reframing can be very powerful. So that's reframing. And the other one I mentioned was counter questioning, where if the parent says, I'll use the why me, why did this happen to me? Well, why not you? Yeah. Now, again, timing, you can't do that one at the hospital or, the day they
No,
get the hearing aid or the day they get the autism diagnosis.
yeah.
Or a parent counter question. Another example would be a parent who asks, do I need to be present for the therapy sessions? Do I need to attend them? Counter question would be, do you want to attend them? And you just kind of lay it at their doorstep. Counter questioning is good when you want to force people to go back and rely on their own resources, their own intellectual resources.
Mm-hmm.
And you pose that question to them, and then you just, let them process that, and, they'll come up with the answer. So, but timing is crucial. And sometimes another micro skill does deal with that informational counseling piece where a parent says, what causes learning disabilities? Well, that's a time where you can actually bring in an informational piece that it's probably a multifactorial condition and lots of things contribute to learning disabilities. And we can also do silence. When you don't know what else to say, don't be so quick to jump in and fill the void just because there's an awkward or uncomfortable silence. Like counter questioning, that forces people back into their own intellectual resources and let them decide where that's going to go next, that next step. Yeah.
Yeah, I like that. I like that. Yes. Good, good,
Yeah.
good. That sort of slides us into the how to manage difficult situations, and during conversations and so on. And, let's just pick a couple. I mean, I have here on my list, you could, do whichever ones that you want. The client doesn't want to or isn't doing their speech language homework or mile homework, or maybe client's behavior. They're interrupting the learning of others in the group if you're doing group therapy in the schools and so on, and also interrupting the learning for themselves. Or maybe a parent doesn't want their child in therapy, or the parent is complaining that they're not making progress. Any of those sound like something you'd like to talk with us
I guess
about?
I'll deal with the parent not wanting their child in therapy. Now, more times than not in the schools, the parents want therapy and the child's not eligible, is ineligible for services. But it does happen. I did have one instance I remember early in my career, had a phonologically disordered child, severe, probably the most severe phonological disorder I've ever seen. It seems like you see those really severe cases early on. Maybe they just seem severe because you're a new clinician, and you get more comfortable over the years. But this dad just had what I felt was an arbitrary rule that he recognized. The two older siblings had a phonological disorder as well. He just had an arbitrary rule that the child, even though she qualified at the age of 3, she was not going to get services. He was not going to consent to services until she was in kindergarten, that magic age, what seemed to him to be a magic age of 5. And, I'm not the legal guardian. I really I don't see the school system fighting this long, lengthy court battle, to get this child into therapy when the parents, and it was dad. Mom was okay with it. Dad was not.
I've had a couple dads through the years. Yeah. That didn't want their child in therapy. Yeah. That's a whole other issue, isn't it?
Yeah, it is. And the dynamics in the home, because the mom, in this case, seem to be very submissive to her husband. And, she would say, I'll work on him, that kind of thing. It's like, okay, well, I encourage that, you all let me know. I just have to come at that because my school system was not going to go, like I said, and battle in court, because they're battling the parents who do want therapy and the child doesn't qualify.
Right.
I just come at that from it's a place of respect for the legal guardians, and all I can do is give them the information piece of what a phonological disorder is and how it likely will impact reading and development of other skills. And with this child, it had social ramifications as well. And so I just come at it as at a place from respect, and I'm here when you need me. And he did sign the consent when the child, was 5 years old and in kindergarten, but it wasn't personal. And I think as a young clinician, we just take things, maybe it's with age, I just take things less personally. It's really not, oh, that's another mantra. It's not about me. That's another good counseling mantra. This is not about me. But early on, I just thought, well, why wouldn't anyone want their child to have speech, to have therapy? It's not personal, though. It wasn't anything that I could tell about the father not liking me as a person or a clinician. That was his dominion to have that, that control over the situation. I respect that. Here's the information. Here's my information. If you change your mind, if you have more questions, if you want to talk about this and explore this further, I'm here. And then I move on and I focus my energy on the people who are accepting of services, and I put my energy into that. I channel it that way.
Yeah. And then you document the heck out of it.
Oh, of course, absolutely. Yes, that can
'Cause
go.
it can come
It's
back to
important to
bite
say,
you.
but it can
Yeah.
go without saying. But yeah, one of the points I wanted to mention with this is something so simple that makes a huge difference. When you anticipate, because I call it not just the butterflies in the stomach, the condors, the California condors in my stomach. You're going into a meeting that may be tense, is likely to be tense. Something so simple you can do. Two things. Do not have a situation where all the professionals are sitting around one side of the table and the parent or the parents are on the other side.
I hate that.
You're setting up a visibly adversarial situation.
Yeah.
And another one, just have some water, a pitcher of water. I try not to use water bottles, but a pitcher of water and, some cups. Just because when we get upset, when we get anxious and tense, our mouth gets dry. That's something so simple. You can have a box of Kleenex there if you think people are going to get upset. And then I'll always have, especially if there's not a child in the room, like some little hard candies or something, just to give a little more down to earth atmosphere with families. That's a good thing to do. If you think it's going to get tense, another thing you can do is let's establish a time period. How long are we going to meet today? And then we'll do a follow-up meeting. And that kind of allows for a cooling off as well. It keeps people more on task, but if things are going to get heated, it allows for a cooling off before people start saying things that maybe they don't really mean to say. And something else that we can do is, if you are working with what Dave Luderman calls the unattractive parent, and I tell my students it has nothing to do with looks. The parent you just are having trouble building that unconditional positive regard for, you're having trouble finding the positives, you can start the meeting with, what are the things we agree on? And one easy thing is, we all want, if it's a pediatric example, we all want what's best for this child. There's at least 2 or 3 things you can build some kind of consensus on, and that'll kind of set a foundation for where we go from there. So those are some things that I have found help. Some are very little things that we might overlook, like the sitting on opposite sides, and then the building consensus.
Yeah.
Those things help.
Yeah. I totally agree. And you can kind of tell sometimes if you have a parent that comes in and they don't look at anybody and they kind of sit off to the side and they don't put their hands on the table. I look at hands on the table as an indication that people feel part of the meeting.
I'm
And
literally at the table. Yeah, mentally and physically.
Yes. But if they're kind of pulled back, their chair is pulled back from the table and their hands are in their lap, or they look down, then I think that's when you get over there with the water and, how was your drive here, or
Yeah.
whatever, or,
Yeah, and I
oh,
appreciate you taking the time to come to the meeting. I appreciate you taking time off work to be here. You
mm-hmm,
know, that shows me that I know you care about your child and your child is a priority, and I appreciate that. Even if things take a negative turn, it doesn't cost us anything to thank the parent or the caregiver, the guardian, the foster parent for attending the meeting. And something else is detaching. We have to learn to detach the parent in this case from the problem. The two are not the same. The parent is not one and the same and synonymous with the problem. Sometimes I think it's easy to get caught up in, oh, this is just a difficult person and I'm not ever going to, maybe you won't make big inroads with this person, but if you can try and see them as a person and not the problem, that seems to help too.
mm-hmm,
Little things that can add up to make a big difference, so to speak.
mm-hmm, mm-hmm.
Yeah.
Yeah. Oh yeah, it's
And don't
complex.
turn, this happened to me, not me, but I was in an IEP meeting one time that was, pretty contentious. And one of my colleagues turned her back when she went to talk to the parent. She turned her back on our special ed supervisor and turned completely away from our boss, the special ed coordinator, to the parent. And now that's just, nothing was said. There's not anything verbalized about it. But boy, my special ed supervisor, really, and I understand. I mean, that just that created some really negative feelings there.
Oh dear.
That you're not on the team, you know, turning your back on someone completely, that was really perceived. So like you were saying, those gestures and that body posture and the hands on those things make a difference. And so we have to, as professionals, I'm a naturally tense person and so I'm a teeth clencher, and I just try and catch myself in those, in any kind of tense situation at work, especially, open body posture and not just tightening up. And because my instinct is, I think it's human to just kind of draw into your shell, into yourself, but maintaining a body posture that says, I'm receptive, to what's happening here. And yeah, those little things make a big difference. But the
I
turning the
think they
back
do.
thing was talked about for months.
Oh my gosh, are you serious?
Oh yeah, it created some really
Oh my
bad feelings. And in my
gosh.
special, and it was so obvious, you know, so those little things, those micro behaviors, they can make a big difference, and they can be perceived it was perceived very negatively. And
Wow.
I understand why. So
Yeah, yeah, that may be taking it too far. I
yeah,
would think maybe just turning your body a bit, or
well,
moving your hands over there,
or to
or your
listen
knees
better,
looking.
leaning in.
That's
Yeah.
right. Yeah,
Yeah,
yeah.
but
Then
turning
that,
completely and
and
putting your
shutting out.
yeah, that was yeah.
Yeah, that's probably not something that you want to do
Yeah, it's not gonna
with
help
anybody.
your career path.
Yeah, yeah, yeah.
Yeah,
Oh my gosh, yeah.
yeah.
Oh my gosh. Well, this is so good. Now, when you and I were talking early in the week,
Mhm.
you mentioned that you had a good story about a professor. Do you remember what that was?
Yes, yes.
Oh, because I've been thinking, I thought, what is this good story going to be?
Yeah, yeah. So, and I
Want to
read
share that?
this was, I read this years ago, but I do this with my students. I don't know, I'm sure I have students who will listen to your podcast. They tell me they listen to it. So they're going to know one of my secrets, that how I start out my counseling class. I do a unit on language changing, with my students. When we give a compliment to someone, we don't put hey, I like your hair, but, you
Mm,
don't want to negate the compliment by putting the but or the however,
yeah.
in there. So we do language changing, and I tell them a story about a professor who brought some cookies into class one day to his students. And I teach college students every day. So, hey, free food, they're going for it. The professor hands out the cookies off a tray. You know, the students can take one at their desk and, you know, a cookie off the tray. And the students are sitting there enjoying the cookies. They're eating them, digesting the cookies. And then the professor holds up, he hasn't shown them the container. The container is a bag and it says dog cookies written on it. I know. Now they weren't really, this is just, you know, for effect.
Yeah.
But the point of the story is language matters. You know, their whole perception of the cookie, it changed when they found out, oh, this came out of a bag. It's a dog cookie. You know, just seeing those words, that language there, it changes perception. He didn't really feed them dog cookies, but the point being, even if you're enjoying the cookie, if I call it a dog cookie or a dog biscuit or a doggy treat, oh, that really changes the impact of that cookie. It doesn't taste nearly as good. I don't enjoy it at all. I might even go spit it out in the trash can. And so I always think about that with, like he says, and the point being, we digest the language we use. And so we have to remember, you know, when we're talking with patients and families, they're digesting and we're digesting the language that they use. So yeah, I love the cookie story. I want to do that with my students, but see, they're going to listen to your podcast, and when I bring in cookies on a tray, they're going to be suspicious. So I'll have to come up with some other way to do that.
Well,
or at least tell the ones who listen to the podcast.
That's it. Yeah. Don't spoil it for everybody else. Yeah.
Don't spoil it. Yeah. Yeah. Get a good reaction from them.
That's right. Oh my gosh. I love it. Yeah, that is a good story. I like that.
It's a good one. Yeah.
Yeah.
I'm going to do that.
Yeah. I'm wondering how it could work the other direction, you know, like, you know, I mean, my husband's not here anymore, but if I made a dinner and, you know, if I pulled out the filet mignon, you know, a wrapper or something, and he's thinking that this little piece of meat is filet mignon, if it would taste any better.
You know, oh yes, spin it the other direction. Yeah. And maybe it's USDA grade F.
Yeah. That's right.
Or mystery meat. Yeah.
Mystery meat. Yes.
Yeah. You could, I didn't think about that. You could spin it the other way.
Spin it the other way. There you go.
That's good flexible thinking, Char. See, you're flexible in your thinking. Yeah.
There you go. Yeah. Also, cooking is not my strong suit either, but
I think I'm an okay cook. It's not something, of course, I have to cook. You know, I'm cooking for a family, so it's more a chore. So.
Yeah. Oh yeah. Well, and it's all a chemistry experiment for me. It's at any rate, thank you so much, Hope, for your really practical, down to earth information, your expertise, and your willingness to share it. Thank you so much. Thank you.
And I apologize to your viewers, the lighting for my camera. I don't know what happened with it, but I do apologize. I recognize that it kind of washes me out, but
you look very pretty.
Well,
No, I think it's,
thank you. So
I know that it's, you know, it's variety.
Yes,
it's variety.
It's the sepia tone, as you call it.
It's the sepia, and we're just going with it.
Well, yeah, we just roll with it. Yeah,
exactly. And in closing, I do want to thank everybody for being here and for tuning in, and for continuing to get the word out about the SpeechLink podcast. And thanks so much for your supportive comments and your good reviews on those apps. All righty. Thank you again, Hope. And to all of you, I hope everybody realizes just how much you are appreciated. Thank you for all that you do for your therapy clients. And we'll see you again soon. Bye-bye.